Okay, when we talk about metabolic alkalosis is very similar to metabolic acidosis in that there are multiple things that can cause it. When we talk about metabolic alkalosis, remember that metabolic alkalosis is a pH that's greater than 7.4 with a bicarb that's greater than 26. I'll say that again. Metabolic alkalosis is a pH greater than 7.4 with a bicarb greater than 26. And metabolic alkalosis breaks down to one of two things. It's either because the patient has too little hydrogen or it's because the patient has too much bicarb. And if you don't remember anything else about metabolic alkalosis, remember this. Usually, metabolic alkalosis is because of an electrolyte problem. I'll say that again. Usually, metabolic alkalosis is because of an electrolyte deficiency specifically. And those deficiencies can be because of a loss of hydrogen, because of a loss of potassium, because of a loss of sodium, or because of a loss of chloride. Any one of those things can cause us to have metabolic alkalosis. Okay, so let's kind of talk about the more common reasons why we would have those deficiencies in electrolytes. So when we talk about loss of chloride, there are basically two places where we lose chloride. And they both boil down to the stomach. So let's talk about what happens when we normally digest food. So normally when I eat food and I digest it into my stomach, the presence of food in my stomach makes me sequester hydrogen and chloride. So all this chloride and hydrogen that's in my blood gets pushed into my belly to make hydrochloric acid. Now, as I'm making hydrochloric acid, my chloride level is falling because I'm using lots of chloride to make hydrochloric acid. As my chloride starts to fall, my body compensates by increasing the amount of bicarb that's available. So as chloride falls, bicarb goes up. Now, the reason why I don't normally have problems is because once this food has all been digested, it's this nice acidic substance now, I dump it into my intestines. As I dump it into my intestines, my pancreas sequesters a bunch of bicarb and pushes all that bicarb into my intestines to neutralize the acid. So the bicarb that was being built up while I was sucking chloride into my stomach now gets used up by my pancreas. The problems come when we circumvent that system. And the first way we can circumvent that system is with lots and lots of throwing up. If we're throwing up and throwing up and throwing up and throwing up, we're using up chloride and using up chloride and using up chloride, and the body is responding by making more bicarb and making more bicarb and making more bicarb. But the problem is the bicarb never gets used up by the pancreas. The other way that this can occur is actually because of the fact that I stick an NG tube down and I keep sucking stuff out of your stomach. If I take an NG tube and I stick it down and put it on continuous suction, I'm going to suck chloride and suck chloride and suck chloride. So again, as chloride is being sequestered into the stomach, the bicarb level is going up and up and up. And again, the pancreas never gets to use up that excess bicarb. So I end up with more bicarb than I have hydrogen, and I end up with metabolic alkalosis. The second big place where we can have metabolic alkalosis caused by renal problems is actually through, the second place where we can have big metabolic alkalosis problems is actually through the renal system. Now, when we talk about the renal system, remember one of the big things that makes our kidneys do what they do is actually something called aldosterone. And aldosterone's big focus in the body is actually to suck up sodium and salt and pee it out. That's the way that aldosterone works is it tells our kidneys to hold on to sodium and to hold on to chloride, and because sodium is hyperosmolar, because it's a big substance or a heavy substance, as our kidneys spit out sodium, as that aldosterone tells our kidneys to spit out sodium, the response is water gets dragged with it. And that's where a lot of our urination actually comes from, is from that aldosterone. Now, one of the things that we can have happen is we can actually have something called hyperaldosteronism. And when we have hyperaldosteronism, what happens is we continue to pee sodium and continue to pee sodium and continue to pee sodium. Well, as we're dragging all that sodium with us, because sodium is positive, it has to take something with it. And what does sodium take that's negative? Chloride. So as I'm sucking up chloride, as that's all being used up in my hyperaldosteronism, the body responds by increasing the level of bicarb. And again, we get to where there's more bicarb than there is hydrogen, and we end up in metabolic alkalosis. We can also see renal losses because of diuretics or steroids. When we talk about diuretics, most of the diuretics that cause metabolic alkalosis are actually because they're not potassium-sparing diuretics. And when we talk about the normal kidney, in the normal kidney we actually have something called potassium-sodium pumps. And potassium-sodium pumps, their kind of whole focus in life is actually to get rid of, I said potassium-sodium pumps, I'm sorry, I meant potassium-hydrogen pumps. When we talk about the normal kidney, we have these potassium-hydrogen pumps, and the big thing that they do is they get rid of potassium. We all know that every time we pee, we're excreting potassium. But the kidney is smart enough that it recognizes when the potassium level is low enough that it can't get rid of potassium anymore. And these potassium hydrogen pumps are designed so that when we can no longer get rid of potassium, when we get to a point where our potassium level is too low for us to excrete potassium anymore, the kidney will switch and start getting rid of hydrogen. So the potassium hydrogen pump is then getting rid of hydrogen instead of getting rid of potassium. And where we see this happen a lot, the most common place where we see metabolic alkalosis from this cause is actually in patients who are taking diuretics and then stop taking their supplemental potassium. In these patients, they continue to take like their Lasix, and as they're taking Lasix and taking Lasix, they're peeing potassium and peeing potassium and peeing potassium, and when they stop taking their potassium supplement, their potassium level starts to fall and fall until their body is smart enough to recognize, I can't pee potassium anymore. If I pee any more potassium, I'm going to kill myself. And at that point, it switches to getting rid of hydrogen. Well, as hydrogen levels start to fall in relation to bicarb, we get metabolic alkalosis. So those are the more common reasons why we would see metabolic alkalosis, by and far the most common reasons. Now, other things that would cause metabolic alkalosis, if somebody actually overdosed on antacids or something like that, that could also cause metabolic alkalosis. But by and far, for the most part, most of our metabolic alkalosis is either because of a loss of chloride in the GI system, or because of a loss of chloride or potassium in the renal system. In either case, the way that we treat this is the same. The big thing that we do for these patients is we identify which electrolyte is missing, and we put them on a course to replace that electrolyte. So when somebody hands you a blood gas and you look at it and you go through and you calculate it and you go, oh, this is metabolic alkalosis, your very next question should be, what are the patient's electrolytes? I want to know what their sodium is, I want to know what their calcium is, I want to know what their magnesium is, I want to know what their potassium is, I want to know what their chloride is. And if one of those things is missing, then the way we treat it is, the way we treat the metabolic alkalosis is we treat the electrolyte deficiency. By treating the electrolyte deficiency, by replacing chloride that's been lost in the form of normal saline, or whether it's by giving the patient potassium who's potassium depleted because of loop diuretics, by doing that, we bring that electrolyte balance back up to where it should be, and by doing that, by bringing that electrolyte balance where it should be, that in and of itself will fix the metabolic alkalosis most of the time. Okay, let's take a break here, and when we move on, we'll talk about mechanical ventilation. In the interim, if I don't see you in just a few minutes, I hope that you have a great day, and I will talk with you soon. I've come for